Yes, you can go ahead.
You might need to start again.
Good morning, my teachers, my seniors, and my colleagues. I'll be presenting practice question for Station 10 of the October 2021 exam. A 44-year-old man with 2-month history of abdominal pain, a month history of weight loss. He has jaundice and melena. Endoscopy image of esophageal varices and bleeding shown. Has hepatomegaly, scratch marks, no stigmata of chronic liver disease. Hepatitis B surface antigen positive and lentivirus negative. Endoscopy picture. What is the diagnosis of the scenario? Mechanism of the pathology seen. What medicine do you use to prevent bleeding? What is the definitive treatment? In an attempt to answer question A, no picture was given. However, I just came up with some endoscopic picture to look at it. Possibly we'll have more input from our colleagues in gastro. So here I just showing this endoscopic varices, gets up mucosa veins, nearly painted. They were one by the right on this picture. But there are some signs that are normally seen on varices. There's one called the red whale signs. They are red patches or streaks on the varices, and as a sign of an increased risk of bleeding or bleeding that has already taken place. As can be seen on these slides, it's showing varices, but you can see some red patches around the reddish area. Then we have also varices on varices, also a sign on endoscopy. They are like small varices and are superimposed on larger ones, and they are often considered to be among the risky signs too. Like in these slides, you see some smaller varices and superimposed on other large varices. Then these are generally some of the findings that may indicate that may give insight on endoscopy. You can have active bleeding. So this one, there will be visualization of evidence of active blood oozing out from the varices, which may present as stream or pool of blood within the esophageal lumen. Then they can be clot or blood adherent to varices. So the presence of blood clot or adherent to the surface of esophageal varices will indicate a recent hemorrhage. Then the red weight sign, we have looked at it already, is a linear or streaked red mark on the variceal surface, also known as the red weight sign, which represent area of recent hemorrhage or erosion. So these abnormalities are indicative of increased risks of variceal bleeding and necessitating prompt intervention to control bleeding and prevent further complications. Again, I came across the modified Packworth classification for esophageal varices, just showing the extent to which they are protruded to the lumen of the esophagus. So they can be grade 1, grade 2, grade 3. So if it's just extending above the mucosal level is grade 1, as seen in the first picture by the left. If it's grade 2, it's projecting up to 1/3 of the luminal diameter, then it's grade 2. Projecting up to 50% or occluding the luminal diameter, then it's grade 3. and it can be as severe as the last picture, almost occluding the total diameter. Question 2, what is the diagnosis? The diagnosis uh, is hepatitis B virus-related hepatocellular carcinoma with portal hypertension from probable portal vein tumor thrombosis. Because the patient they said he had no chronic stigmata of liver disease. Uh, he, he had hepatomegaly and he had weight loss, but I will explain further when I'm presenting. Mechanism of the pathology, that is that seen in the on the picture, on the endoscopy picture. So esophageal varices are dilated submucosal esophageal vein. They are connecting the portal and systemic circulation. They are formed due to portal hypertension, which commonly is a result of cirrhosis, can be as a result of resistance to portal blood flow and increased portal venous blood inflow. The severity of liver disease correlates with the presence of varices and the risk of bleeding. What medicine do you use to prevent bleeding? Propranolol is the first choice. Carvedilol could also be an alternative option. That is a non-selective beta blocker. What is the definitive diagnosis? Definitive diagnosis for esophageal varices is endoscopic variceal ligation. So endoscopic treatments are the cornerstone, and it can be sclerotherapy or the endoscopic variceal ligation. But the endoscopic variceal ligation is the most preferred. Discussion. Hepatocellular carcinoma is the most common type of primary liver cell cancer, which in turn accounts for the sixth most common cancer worldwide. Despite being the sixth most common cancer, it is the second leading cause of cancer-related death. Hepatocellular carcinoma typically arises in the background of cirrhosis. But however, like the case presented, in 20% of cases, it can develop in a non-cirrhotic liver. This is evident because it was mentioned that the patient has no chronic stigmata of liver disease. He had hepatomegaly, he had abdominal pain, and he had weight loss. And this particular subgroup of hepatocellular carcinoma, they generally present at an advanced stage because the surveillance is not normally done since they had no cirrhotic liver ab initio. Complication of hepatocellular carcinoma, as shown, hepatic encephalopathy, portal vein thrombosis, worsening ascites, variceal bleeding, obstructive jaundice, pyogenic liver abscess, intraperitoneal bleeding. For this case, sorry, my slide. Causes of portal vein hypertension are shown. It can be pre-hepatic, it can be hepatic, and post-hepatic. Just to mention some, like in this case, I'm thinking of portal vein thrombosis, that is a pre-hepatic. It can be hepatic, meaning if there's presence of cirrhotic liver because of the fibrosis, preventing blood flow and causing portal hypertension. Then it can be post-hepatic, like the Budd-Chiari syndrome, and also liver cardiac failure. Esophageal varices are dilated submucosal veins connected. Sorry, I've already mentioned this slide. Esophageal varices, they are common and is a poor prognostic factor for patients with hepatocellular carcinoma. Without treatment, between 20 to 40% of patients with varices will experience an episode of severe bleeding, resulting in significant illness or even death. Approximately 15% of people who bleed from varices will die, emphasizing the importance of preventing bleeding and treating the liver disease. Prevention of the variceal bleeding, as mentioned, is propranolol, non-selective, but carvedilol and nadolol can be an alternative uh, option. However, the endoscopic variceal ligation can be offered to patients who are unable to use non-selective beta blocker or patients in whom the drug therapy has failed. Management for acute variceal hemorrhage, it consists of the use of vasoactive drug, also the use of endoscopic band ligation and antibiotic prophylaxis. Also, the transjugular intrahepatic photosystemic shunt is reserved for those who do not respond or are unlikely to respond to initial standard management. The vasoactive agents used are the terlipressin, the octreotide, and the somatostatins. They are associated with significant lower rates of acute all-cause mortality and transfusion requirement, and they improve control of bleeding and shorter hospital stay. The other is just explaining that terlipressin is an analog of vasopressin. Management of urgent endoscopy is necessary for variceal hemorrhage too. Emergency fiber optic endoscopy can confirm the diagnosis and source of bleeding. Urgent endoscopy in unwell patients is not without its risks. Adequate staffing and presence of resuscitation facilities are required. But endoscopy allows the bleeding point to be visualized and treated. Band ligation is a first choice of the treatment, as has been mentioned. Sclerotherapy is another choice. It's widely used. However, the endoscopic variceal ligation is the preferred. Other measures that can be used in acute emergency setting is the balloon tube tamponade, like the Stenkin-Blakemore tube, can be used to cause tamponade and prevent bleeding. The transjugular intrahepatic photosystemic shunt is recommended as a choice of treatment for uncontrolled variceal hemorrhage. And surgery is another mode. Esophageal transection and gastric devascularization, they are rare procedure, but they have a role for patients with portal and splenic vein thrombosis who are not suitable and candidate for shunt procedures and who continue to have variceal bleeding despite endoscopic and pharmacological treatment. Liver transplantation is a treatment of choice for patients with advanced liver. Endoscopic screening is important for all patients that are newly diagnosed for cirrhosis, but just like in the case we saw, it's hepatocellular carcinoma occurring in non-cirrhotic liver, so that presents a challenge. It's actually the drawback for cases like that because there are no cirrhosis ab initio, so they might be endoscopic screening may not be instituted. So, but for all cases of newly diagnosed cirrhosis, uh, screening endoscopy is advised, looking for endoscopic varices, esophageal varices, sorry. The presence of moderate or large varices required beta blocker in the first instance, and if there are contraindication to beta blockers, the varices could be banded or sclerosed. In the long term, repeated endoscopic screening is usually required, like 2 to 3 years interval in cases of small varices. Patients who have survived uh, um, esophageal variceal bleed should receive beta blocker plus or minus nitrate and endoscopic screening and treatment. Variceal bleeding prognosis for patients with cirrhosis, 1 year survival is 50%. For those surviving 2 weeks following a variceal bleeding. Prognosis in non-cirrhotic portal fibrosis is better than for the cirrhotic cases. Associated renal, respiratory, cardiovascular, and immune disorder account for 20 to 65% of mortality in patients with esophageal varices. I made some notes on hepatocellular carcinoma, just few mention. The statistics shows that hepatocellular carcinoma in Africa showed a geographical variation with higher rates reported in West Africa countries compared to the rest of the continent. And the global impact is that it's the sixth common cancer and the third leading cause of cancer-related death. Pathophysiology, I'm just mentioning this briefly. I know my time is gone. Pathophysiology for hepatocellular carcinoma involve hepatic injury because of chronic inflammation, and that then we can have fibrosis and cirrhosis. Then it can be due from genetic mutations. The mechanisms involve angiogenesis. The cells are stimulate the growth of new blood vessels, ensuring continuous blood supply for their survival and expansion. Metastasis, another form, and tumor microenvironment creation is another. The risk factors for hepatocellular carcinomas, as we know, is viral infection, hepatitis B, hepatitis C, chronic alcohol intake, and metabolic syndrome from non-alcoholic fatty liver disease, just to mention a few.
Just round
Sir,
up. You have 1 minute. Round up.
okay.
Just
Thank you, sir. Investigations, ultrasound, MRI for detailed images, biopsy. However, this is not regularly done. Alpha fetoprotein is a very important measurement in this. It's elevated in 75% of cases. The level of elevation correlates inversely with prognosis. An elevation of greater than 400 nanogram per ml predicts hepatocellular carcinoma with specificity greater than 95. I think the others are just the treatment option can be surgical resection, transplantation, and ablation processes. I think the rest will be shared on the slides I will post on the group. Thank you for listening.
All right. Thank you, Dr. Jeremiah, for your presentation. So this time for so can you go back to the first page for the question? Go back to the question. So welcome contribution and comment. Okay, Dr. Ejiro says signs seen on endoscopy: red wheals and hematocystic spots, cherry red spot, white nipples spots, diffuse erythema. Dr. Ifoma said telepressin is also used to control bleeding. Ejiro say endoscopic varicella ligation can be used for primary prevention. Then Dr. Momodo said, what stage will you put the red wheal and varices? The red wheal and varices on varices using the packet classification. Are there other classification for varices? Dr. Jeremiah.
Hello, sir.
Yes, I just read the question from Momodo.
Okay. I didn't, sorry, I didn't check for other classifications of varices. I may need help in that regard. For the stage, the Piquet classification, I only looked at it in regards to the level of occlusion of the esophageal lumen. I wouldn't know where to place that. I may need help.
So any do you have any?
Dr. Kute, please, the person that asked the question, if he has more to say, let him tell us.
No, thank you, teachers and colleagues. So the red wave signs, the typically packet will have stage 1, 2, and 3. But there's this pseudo stage 4, and that's how they actually is not official under the official packet classification. But when you see all those red wave signs or the varices on varices, which are considered very high risk signs of bleeding, is typically termed like the pseudo grade 4. Then you also have the Japanese Research Society for portal hypertension classification. This one has shown to actually help you to classify the severity of bleeding risk more compared to other studies. Then you have the Dagradi study too, Dagradi classification. That one grades from grade 1 to grade 5. Thank you.
Thank you very much. I appreciate it.
Thank you. Thank you. Thank you. Any other?
Hello, please. I have a comment, please.
Okay.
Good morning.
Dr. Tanimu's hand is up.
Okay.
Okay.
Can I take my comment?
Yeah. Okay.
Please. Sorry, it's just a question I wanted to ask the presenter. He discussed hepatocellular carcinoma. And in the notes he gave us hepatocellular carcinoma, when he talked about diagnosis, I was expecting maybe to talk about the triphasic CT, that is one of the newer ways of diagnosing hepatocellular carcinoma. So I don't know whether he didn't, whether it was intentional or probably had his reasons. The role of triphasic CT in diagnosis of hepatocellular carcinoma. So, all right, thank you.
Okay, Dr. Tanimu, can I make a comment before you respond?
Thank you very much for this very good presentation. Also, when we are looking at a question, we have to find the salient words there and the salient investigation. They say hepatitis B surface antigen positive. So when we are making the diagnosis, we have to capture that surface antigen that is positive by saying hepatitis B virus related hepatocellular carcinoma complicated by biracial bleeding. So that we capture everything, the material they supplied to us in the question. And also for us, this you said propranolol. Usually, I think I don't know whether the teaching have changed, but propranolol for this question they said, what do you use to control the bleeding? This one is the propranolol is for prevention. So for control of the bleeding, I think if the teaching have not changed, is teliprecin, octreotide and somatostatin. That is for the control of this current bleeding. But that is, I think, is not the propranolol. The propranolol is prevention, but for the control in the current bleeding is either teliprecin, somatostatin, or octreotide. And we should get to know that liver cirrhosis, cirrhotic liver does not mean shrunken liver. In some cases, shrunken liver, a large liver can be liver cirrhosis, but commonly it's shrunken. And also, we have to be very cautious about a question set without abdominal pain. Usually, if it is hepatocellular carcinoma, sometimes they get a picture or they said they also about abdominal pain, usually, but we stand also to be much corrected. Thank you very much. It's a very good presentation. Thank you.
Okay, thank you, Dr. Tanimu. Okay. 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 Doctor, I'm going back to the. Okay, there's also forest staging for esophageal virus. This for non-esophageal, non-varicose bleeding. Dr. Ayodiji. Then thanks for Dr. Nwata said, thanks for presentation. What's the role of antibiotics in varicose or Paget bleeding? Dr. Ejiro said there's sarin classification for varices. Dr. Nwata said, what's the difference between Blakemore tube from Minnesota tube? Dr. Charles said, I'm wondering how he arrived at portal vein thrombosis in the diagnosis. Thank you for An excellent presentation. Dr. Olaleko, good morning. Thank you for your Can the diagnosis be put for HBV-induced chronic liver disease complicated by varicose bleeding? Dr. Tanimu mentioned something like that. Dr. Chika said, thank you for the presentation. What about the management of chronic hepatitis B? Did you get all those? Did you get all those?
Yes, sir.
Okay.
Hello.
There are some. Yes. So
Okay.
can you? Yes. Can you just attempt? If.
Okay. Thank you very much. Thanks for the comments and the questions. I will make an attempt and we call for help. For one of the comments, you talk about the medicine that was used. The question was not on the treatment of bleeding, as shown. The question said, what medicine will you use to prevent bleeding? So that was why propranolol was mentioned. Then the role of antibiotics in bleeding, varicose bleeding. I read that in fact, prophylactically, antibiotics is given because it has been shown to give good outcome, and that in many percentage of that of such cases, there's coexisting infection. So prophylactic antibiotics is even part of the management. Even in the absence of signs of infection, prophylactic antibiotics is very important to help and to give good outcome. But I didn't see much to know of other reasons why those antibiotics are indicated. For the questions about triphasic CT, looking at the questions, I was going towards discussing varicose bleeding. Since most of the question was directed towards varicose bleeding, I mentioned, I talked on hepatocellular carcinoma just briefly, since the question was focused more on varicose bleeding. But I'm aware that triphasic CT is one of the recent investigation that is used in this regard. I know that it has three phases: the non-contrast phase, the arterial phase, and the portal venous phase. And it's very important in the diagnostic process for hepatocellular carcinoma. However, I don't have details, the radiological details for that procedure. I don't know. I may have forgotten any other question.
Okay. All right. So thank you for your presentation. Okay. So well, the question is about varicose, bleeding, and then probably the picture, we couldn't get the picture. So the diagnosis will be decompensated liver disease. Okay, decompensated liver disease secondary to chronic hepatitis B virus, and then complicated with esophageal, viruses. Well, depending on what the picture say, you can grade it using the packet classification. If it's grade 1, grade 2, grade 3, or grade 4. So the picture would have given us a better diagnosis to give us a complete diagnosis, okay, for the hepatitis. And then, well, even though you have weight loss, jaundice, okay, so those also can serve as probably, some form of, malignant transformation, and could also be from PLCC. So, but if you say decompensated liver disease is more of a spectrum, so it could be cirrhotic, it could be PLCC. So, and then with the viruses that are complicated. Okay, so not necessarily people with, hepatitis will come down with stigmata of CLD. Usually stigmata of CLD, we get them more with those that take alcohol. So liver disease from alcohol, even though yes, you can get it from viral hepatitis. Then go back to the question again. Let's look at the question again. The question, the next page, please. Okay, so then they see the mechanism of the pathology scene. So this is viruses, and basically, okay, there's increased, blood flow through the portal system, and then there's probably resistance from the outflow most of the times, and then nitric oxide is the key there. So there's decrease in pathetic tone, there's a decrease, there's vasodilatation, which causes vasodilatation of the splanchnic circulation, and then since it's CLD2, there's some form of translocation of bacteria too. So those two can, contribute in activation of forming nitric oxide, which causes the overall vasodilatation of the splanchnic circulation. Well, they didn't mention how to manage the upper GI bleeding. This is just what medicine do you use to prevent bleeding. So usually we have prophylaxis. You have both primary and secondary prophylaxis. Primary prophylaxis when patient has not bled yet. Then secondary prophylaxis, okay, patient has bled. And then they are also similar management. Okay, so what this simply means for primary prophylaxis, patients can have features of cirrhosis, features of liver disease, initial surveillance to check if there are viruses. So patient has not bled yet. You can ban if it's a bandable virus, or you can give up non-select prevent to reduce the portal, venous pressure. Has bled or is bleeding, has current bleeding, an authentic endoscopy, and then if the patient has bled already and has stopped, there's no active bleeding, you can also bring in your non-selective beta blockers to, as way of prophylaxis, and then you can do, serial banding. Ligation for both primary and non-selective beta blocker for both primary prevention and secondary prevention. And then just to add, for acute bleeding, somebody comes, okay, in the emergency, you want to manage varicose bleeding, you follow your normal, you follow the normal management protocol. You resuscitate, ABC of resuscitation, you get with emphasis on circulation because the patient is losing blood. You give blood and blood products. You give, somatostatin analogs. Okay, telepressid is recommended. Octreotide 2 can be used, okay, to control bleeding. And then, of course, you can use at that stage. You can still use omeprazole because why not? Patients with liver disease too have been found to have, peptic ulcer disease concurrently with liver disease. So it must not always be variceal bleeding in the setting of liver disease. So you can come down with peptic ulcer disease. So when you stabilize this patient, then you can go ahead and do an urgent, endoscopy, usually within 12 hours, so as to look for the cause. So if it is variceal, you band. If it is, non-variceal, then you give appropriate treatment for that. So what's your definitive treatment? Okay, definitive treatment too also depends on the stage of the problem of the disease. Depends on the problem of the disease, the stage of the illness. So for cirrhotic, okay, you want to offer, you want to treat, of course, the hepatitis B, which is the culprit here causing the liver disease. So you want to evaluate for hepatitis B, and give appropriate drug for treatment, and then offer liver transplant. Most of them are liver transplants at the end of the day. For PLCC, depending on the stage also, there are times you can do a resection, you can do, depending on the BCLC stage, it can be resection, it can be transplant, it can be arterial chemoembolization. Okay, it can be even chemotherapy or immunotherapy, as the case may be. So it depends on the stage of treatment of the disease. That's what will decide what the definitive treatment is. But the common pathway is to do, a liver transplant, and then of course there are others, the scoring system to tell you what the CTP, the MELT score, and the likes you will give us. So it is just a summary of the approach. And then antibiotics is very important, because I mentioned translocation of antibacteria. So it has been shown that ceftriaxone, is very important to, as prophylaxis in the setting of cirrhosis. But if it's cirrhotic upper GI bleeding, then the use of antibiotic is not recommended. So that's that. I don't know if I've covered most of. So if we have any other person that can, any other gastro person that can, if there are things that I have left out, that can just okay. So Dr. Olalekan said,
Dr.
okay,
Atta,
so
we might have to
yeah,
take the next. Dr. Atta,
yes, ma'am.
7:40, we might have to take the next question. So let's summarize this one, please.
Okay.
Thank you.
So is there any other clarification or any other?
So, Dr. Atta, I don't know if Dr. Cookie wants to say something. Yes, let us say something.
Okay.
Yeah, Dr. Rengo, good morning. Good morning, everyone. So I think everything has been covered. So I looked at the chat box and I agree with Dr. Ejiro, who said the diagnosis, because there are signs of decompensation. So once a patient with chronic liver disease has jaundice, upper GI bleeding, hepatic encephalopathy, and ascites, once you see any of those four, you must put decompensation in front of your diagnosis. So it's a decompensated HBV-related chronic liver disease complicated by variceal bleeding. So once you mention variceal bleeding, we know that you're talking about an upper GI bleeding, because upper GI bleeding can either be variceal or non-variceal. But in the setting of background HBV infection, because it's liver related, it's a variceal bleeding. And so you also covered the ways of managing this, the variceal bleeding. So EVL can be used, the variceal band ligation can be used, and then the vasoconstrictors in terms of the telipocin, the somatotropin, and what have you, can also be used. Then you have the preventive measures where you use the non-selective beta blocker, but not in the setting of the acute bleed that you use them. And then when you are managing these patients, you give antibiotics, group and cross match. So it's an emergency. So depending on how the patient comes in, so you set 2 white ball cannula, take blood, for grouping and cross matching. Immediately you start your IV fluids, the crystalloids, and then you also give, then you also check for your clotting profile, because you may need to also give other blood products like the fresh frozen plasma and what have you. Then escalate as it goes, because it's a multidisciplinary approach. If this patient goes into shock, you may need ICU admission, And then also, if you are not able to control the bleeding and stabilize this patient hemodynamically, so to be able to control the bleeding endoscopically, the patient may also need tips, done by the interventional radiologist, or the patient can require angiography that the general surgeons will do to go and cut off the splanchnic circulation, in order to prevent the bleeding. And then the definitive therapy in these patients is a liver transplant, because by the time these patients have developed this decompensation, they tells you that this liver, the chances of his recovering are very slim. So this patient would need a liver transplant in the long run. And then, of course, managing the underlying cause, which is the hepatitis B virus. So thanks. Those are my contributions.
Okay. Thank you. Thank you very much, Mo, for the contribution. Okay. So thank you, Dr. Jeremiah, for your presentation. Okay, let me just read some few. So Dr. Ejiro say transfusion varicose hemorrhage is restrictive. Yes, you don't transfuse the way you transfuse for non-varicose hemorrhage, so as not to increase portal vein pressure and then worsening the vomiting, the bleeding. Doctor Justice say we should also consider restrictive transfusion yes protocol with bleeding with aim of minimizing rebel from an increased portal. Okay, he mentioned the goal here is 7 to 9 grams per DL. Yes, most times 21% PCB or 7 grams per DL. When it's less than that, when you start considering, transfusion. So I don't think Austin, Okori, and let me look at their names again. So probably we'll just look at those questions, but I don't think the other guys.
What about the second person that you mentioned earlier? Is the person already?
I'm here.
Okay.
The person is there now. Hey, let him present, please.
All right. So
this is
just
a few weeks to exam. This is few weeks to
so
exam.
just,
The least number we can take is faster. Let's always try to manage our time so we can at least answer 2 questions.
All right, you can go ahead, Dr. Emmanuel.
Right. Good
Dr.
morning.
Emmanuel. Yes,
I'm here. Good morning,
okay.
Teachers, senior colleagues, and colleagues. I'll be taking the practice question October 2021, General Medicine, question 8. This is the question. 65-year-old man, weighs 90. Damage his right anterior cruciate ligament and has been staying alone after his wife died 5 years ago. Pertinent information: he's a known hypertensive, newly diagnosed diabetic, smokes 20 sticks of cigarette a day, and then has alcoholic 28 units per week. And then he presented with left knee pain, worse when ascending and descending the stairs. The question presented were list 4 differential diagnoses. How would you investigate X-ray of the knee, suggest subchondral sclerosis? What's the final diagnosis? What are risk factors? List 4 classes of drugs used in management. This question had initially been tackled by Dr. Sunday Zakaria and Ibrahim Abdullahi Aladu. Just to note that the question was asked for 4 differentials, which could be in this context: left knee osteoarthritis, rheumatoid arthritis, gouty arthritis, pseudo-gout. Other differentials are thus listed below. The next question was, how do you investigate? Started a prompt by the X-ray of the knee suggesting subchondral sclerosis. Of course, X-ray is the image modality of choice. It's cheap, it's cost-effective, and readily available, and then quickly obtained. These are some of the investigation. Of course, that could also be cysts as well as osteophytes. Also, MRI could be an investigation of modality. And then, of course, astrocentosis in the context where we have microscopic culture sensitivity, synovial fluid analysis, and then, of course, checking through polarized microscopy. What is your final diagnosis? Left knee osteoarthritis. And what are risk factors in this context? Patient is elderly. Patient is overweight, triple base. The weight was about 97 kg. Patient was a known footballer. So, of course, the knee has been bearing load, and then he had a previous joint injury, stroke damage. Patient a known diabetic. There's a history of excessive alcohol consumption, and then patient smokes. These 4 classes of drugs used in the management, we could use simple analgesic in the context of using paracetamol, NSAIDs, opioids, capsaicin cream, and then the other ones listed below. So just to talk very briefly about
I think they have presented it. Is there any new information you want to give us? Any new information?
No, I don't think there's any new information at all.
Okay, because I think this is either the 3rd or the 4th time we're presenting this. So that if there are no new information, then we might as well make our contribution. Yes.
Dr. Just allow him summarize, even though there might not be, even though it has been answered, it took his time to prepare the slides. Just allow him at least 5 minutes to just summarize.
Okay, so
all right then. Go ahead.
Thank you.
So, thank you very much, Ma. So osteoarthritis is very common joint disease and presents with pain and deformity, like in the index patient being discussed, and ultimately leads to chronic disability. Important to note that it's a significant medical and financial burden in the world, especially as the population is aging. Basically, in this condition, there are problems with the structures of the joints, and of course, they are accompanied by usually hyaline articular cartilage loss, as well as focal thickness and sclerosis of the subchondral bony plate, outgrowth of osteophytes. This is just a diagram of the synovial joint, and this is the place where a lot of these activities happen. Just to note that it increases the predisposed with increasing age. Of course, our patient was 65 years. That there are common joints affected, the hip joints, the knee joints, and the first metatarsal joints. Usually, the joints spared, especially as regards primary, are the wrist, the elbow, and the ankle joint. This is talking about this condition. Obesity and being overweight have very strong risk factors for this particular condition. And then, of course, strong risk factor for knee osteoarthritis with modest risk for hand osteoarthritis. This is a diagram talking about the relationship between obesity as then leading to osteoarthritis. Just to note that in this condition, there are a lot of things that can happen in the joint space. You can see how the sticking capsule, the limited synovitis, and then subchondral bone of the osteocyte. There are several risk factors. That's one of the questions asked: age, sex, risk-related trauma. Patient had a trauma on the knee, and then, of course, obesity, occupations with sports. The patient was a ligament laxity, reduced muscle strength, impaired joint proprioception, as well as joint hypermobility. The diagram summarizing what I just described. The clinical subtype, they are primary or the idiopathic, and then the secondary, as well as the peripheral axial. We've talked about the areas where it is predisposed to. So clinical symptoms, of course, pain. The patient had pain, that stiffness, reduced muscle movement, and joint movement. That could be swelling, crepitus, and then joint line tenderness, as well as deformities in advanced cases. Diagnosis is basically history and physical examination, of course. However, radiological investigation will serve to confirm the diagnosis and then grade severity and then detect likely complications. These are the investigation modalities that can be used to make that diagnosis. As we said, the hallmark basically is the hypertrophic osteoarthritis, which is localized joint space narrowing, subchondral bone sclerosis, osteophyte formation, as well as bone cyst. MRI is also useful for the investigation. These are other investigative modalities. The ACCRO criteria for the osteoarthritis is not stated in this diagram. There are differentials, which was part of the question asked, rheumatoid arthritis, gouty arthritis, and so on and so forth. The management basically is multidisciplinary. However, it's divided into non-pharmacological, pharmacological, and surgical. And of course, for that, patient will have to reduce weight, advice on exercise and activity. Patient will do well on orthotics and bracing and canes to help in movement. This is a diagram of some of the knee braces commercially available, and some of the workers, available. Pharmacologically, patients will benefit from topical agents, can also benefit from oral analgesics, intraarticular injector, anti-OA drugs. So basically, surgical management is a last resort for patients, and of course, not responding to medical therapy and of course, performance, enormous economic burden and disability, identifiable risk factor. There's a complex pathogenesis, multidisciplinary approach in management, patient education, pain relief, improvement of function, ultimate goals of therapy, and such may be ultimate for some patients. Thank you very much. Thank you very much for listening.
All right. Thank you, Dr. Emmanuel, for a wonderful presentation. So do you have any comments, any contribution? Any comments, any contribution? For our rheumatologists in the house, please, the use of simple analgesics like paracetamol, is it still part of the management, or it has been expunged? Because I think I saw somewhere about paracetamol not recommended as first-line management for osteoarthritis in the control of pain. So this is for the rheumatologists in the house, if you can shed more light on that. Okay, well, Dr. Momodu, thank you for your presentation. Is it commoner in females or affect both gender equally? That's the osteoarthritis. Dr. Emmanuel, if you're listening. Then, okay, yeah, that's the only question.
Okay, it's commoner in females, and especially from age 65, females, that the ratio is usually 1.7 to 1. So it's commoner in females, basically.
You say from age 65? Hello, Dr. Emmanuel.
Hello, sir.
You say from age 65?
No, I said basically it's commoner in females. And then usually, generally females, the female ratio to male ratio, usually, especially for knee joint osteoarthritis, as I said earlier, is 1.7 is to 1. So there are studies that suggest that when the younger women, of course, because of the hormones, they are basically protected from osteoarthritis. However, as they get older, they catch up with men, and then usually is higher. And then also, there are also studies that suggest that for erosive osteoarthritis, female to male ratio is about 12 to 1, but generally, it is more prone in women than in men, generally.
Okay. Dr. Emeka says, thank you for your presentation. What is the guideline now for using intrathecal intra-articular injection. And Dr. Okori said, thank you for the presentation. Please, they should also shed light on the intra-articular medication use. Is there a first line between steroids and viscous supplementation? Will everyone with OA benefit from intra-articular meds, or are there specific indications for intra-articular injection? So Dr. Emmanuel, can you say that?
So I'm trying to read the question because I'm not hearing very well, actually.
Oh, okay.
Well, okay, for the steroids, basically, I don't think I saw any of the guidelines. However, I think one of the things I saw as regards that was that you don't use it more than 4 times in a year. I think that's one of the things I saw about that you don't use more than 4 times in a year. And then there is also a guideline for use as regards the particular joint, okay, joint space, different modalities, which I put on the slide as regards maybe shoulder, knee, hip, elbow, wrist, different modalities for that. I think also, I think that's basically what I saw. I didn't really see much. And then, of course, one of the things I saw is anti-inflammatory, rapid onset of pain relief and function. Then the maximum efficacy is less than 1 week. I think that's basically what I saw. But the effect can last from several weeks to months. I didn't really see anything on guidelines on use. I don't know what that.
Okay.
Yeah.
If there are guidelines for Dr. Emeka, Dr. Charles, you can go ahead and let us know if you saw any guideline anywhere with that in terms of the use of intra-articular injection. Okay. Seems Mecca and Okori have no response. So is there any other contribution?
I actually don't know the answer. I just wanted clarification. I'm not certain.
All right, no problem. Okay, Dr. Momodu says outside the hormones, it's also proposed that some factors might contribute to women's susceptibility to A, which includes thinner cartilage, tendency to varus, malalignment, joint instability, and uneven mechanical loading. Okay, is there any other contribution in terms of aspects before I hand over to Dr. Christopher and our teachers? Okay, Dr. Christopher.
Dr. Tata, thank you. Thank you so much. Thank you. I must commend the 2 speakers today. It was quite session. That first one was quite interactive. I must appreciate the class too for their questions, their comments, and the gastroenterologists in the house for coming in. Please, your comment on paracetamol, last I checked, is still one of the first line drugs, simple analgesia. So please, it's very important.